Okay, we'll go ahead and get started. It's 12 o'clock. My name is Sharice Magoon, and I am with UT Health School of Nursing. You're signed in to hear Dr. Corey Waller addressing pain and MAT, how to talk to patients about opioid use. We are happy to have you join us for the Texas NAS Awareness Month. These free CE presentations are sponsored by Texas Health and Human Services. Before we get started, let me go over a few housekeeping items. We do ask that you please mute your microphones throughout the presentation and also turn your video off. We will take question and answer through chat. Without further ado, let me introduce Dr. Corey Waller. He is a board certified addiction and emergency medicine specialist who has extensive experience working at the local, state, and national levels. He has worked extensively with the American Society of Addiction Medicine and related organizations to advance the evidence-based practice of treatment and recovery for individuals affected by substance use disorders. He is a nationally recognized expert in substance use disorders. He is now the editor-in-chief of the ASAM criteria. Dr. Waller, the show is yours.
Great, thanks, Sharice. I appreciate that. And welcome, everybody. It's always good, even if I'm not home. That's where I grew up, was in Texas, born and raised, born in Dallas, raised in Austin, educated all the way through. Went to medical school actually at University of Texas Health Science Center there in San Antonio. So it's nice to be able to step back in. You know, a 90-minute webinar is a really interesting concept. I think 90 minutes of anything nowadays is a pretty interesting concept, but over this time, I felt like approaching this, starting with really kind of the science, and then really getting to the practical at the end, like what do we do about it? Because learning how to have a conversation with a patient is one thing, but knowing what to do for that patient is completely different. And I find that conversation with a patient who has a substance use disorder and medication-assisted treatment, who has pain or is telling you they have pain, but we can't identify it. What they want are solutions, and how we present those solutions to them is important. But I think that if the vast majority of you guys are nurses or social workers or PAs or nurse practitioners or docs, most people have gotten pretty good at having some of these conversations if you're on this call. So I'm not going to give you 30,000 foot stuff. What I want you to walk away with is some really specific knowledge and a capability to have a conversation with a patient who has a complex substance use disorder and pain, and how we deal with that. And that includes, what are we gonna do if somebody's gotta go to the hospital? I ran a clinic dedicated to pregnant and parenting women with a substance use disorder for a number of years. So I've seen hundreds of pregnant women with substance use disorders from all types. And so I felt like the more that I explained to them what was going on in their brain and how their body was perceiving this and all of that, the more buy-in and trust I got. So what I want to hopefully do during this time is really arm you with the knowledge that it takes to convince the patient that you know what you're doing, and then also advocate for them aggressively with those that either work from the pain group or addiction group or in the hospital, in peripartum, intrapartum, you know, wherever you're seeing them. I think it's important that you're able to address the concerns with specific knowledge. So that's the goal. And from this, we're gonna talk about some of the basic neuroscience of pain. We're gonna learn what we should be doing for kind of post-operative pain in a patient with MAT. I'm gonna jump into some complementary and alternative medicine stuff that has some science behind it. And the specific ones become important because these come up all the time. Dr. Google likes to spit these back out whenever somebody looks up what to do if. And so I want to dig into the science of some of these things that we maybe talk around, but don't know. So like mind-body work, biological based practices, manipulative practices, that kind of stuff. And for all disclosure, I'm a neuromolecular biologist, so I'm a skeptic from the get-go. So what I give you from this is going to be based on the data science and math that we have, and then as we go through. Disclosures, I don't have any. I work, I get a salary and I still practice clinically in the emergency department and cover addiction treatment services at a hospital with a colleague of mine. And then mainly right now, I'm in the process of implementing and building addiction treatment in the entirety of the California prison system and the Michigan prison system. So I'm pretty deep in the criminal justice side of stuff. But I've never gotten a dime from pharma or device or any of those things. So I want to start with talking about a patient that I want us to keep in mind as we go through this. This is a patient of mine, and I use her often because I think she had a lot of very identifiable diagnoses and things to think about, but also just anything that we learn, it's always easier to apply it to an actual human being rather than in general. And so if we start with Kayla and we look at her life stage 1, which would be adolescence, her family history, she had a pretty deep family history of addiction. Her mom and dad both suffered from addiction. Mom was more stable than dad. Dad took off pretty early. That moderate early life trauma came mostly from her dad and was mainly verbal abuse without significant physical abuse. But all of that combined, she started to use some substances early, including marijuana and alcohol. And then she had a elective pregnancy termination at 17, where she had become pregnant. And then her early adulthood, so into her late teens, early 20s, she had then become addicted to opioids after she had been written for some for wisdom teeth, continued to use marijuana and decreased alcohol, but was definitely taking, she was taking right around 100 milligrams a day of Percocet, and poorly controlled anxiety on top of this. So she would use benzodiazepines intermittently. She had physical dependence to these benzos. So if she stopped it, she would feel horrible. She had rebound panic disorders and would definitely have been at risk for seizures. And she's now pregnant. This is when I saw her, when she was referred to my clinic. She has pretty much zero social support at that time. I also want to give you a little bit of a flip that if we had not seen her at this point, the natural history of addiction in someone who looks like this turns into the late adulthood, which is she's lost custody of those kids. She's now got some chronic pain. She's on probation, and she's a high frequency utilizer of the emergency department. And that's a pretty common natural history, that if we don't identify these things and take care of them when we see them, then they progress, and they don't progress positively. They progress to things that we can't really undo. So this is Kayla. Just keep her in mind as we go through early life trauma, opioid and benzodiazepine use disorders, polysubstance use, which is a pretty common reality of this population. When I initially saw her, we started her on buprenorphine at 16 milligrams. She stabilized out, and then over the next 8 months, we weaned her off of benzodiazepines and had her on a low-dose SSRI and down to 12 milligrams of buprenorphine daily. And she'd been doing really well after that first year. So some of these times I'll be talking about her in the case of when she was stable. In some of these cases, I'll talk a little bit about what would happen if she was not stable and if she had relapsed. So before we dig into the neuroscience of pain, I want you guys to know that if you have questions, please ask them in real time, meaning if it's pertinent to what I'm talking about, type it into the chat. I have that up on my computer screen, and I will look at the chat, and I will try to identify those questions as we go through. And that way I can directly address it at the same time that I'm out talking about the other stuff. So many times we recognize that we're seeing patients who complain of pain, and we maybe can't identify what the pain is. And a lot of times it's not necessarily pain, it's more suffering. And I've always kind of liked this quote because it empowers somebody who has pain and suffering to feel like they can have some control over it. So if you are distressed by anything external, the pain is not due to the thing itself, but to your estimate of it. And this, you have the power to revoke at any moment. And this is really when we talk about the mindfulness-based cognitive therapies, meditation, hypnosis, those things like that. That's what we're really talking about. Is it's not so much about what's actually happening, but how you perceive what's actually happening. And I'll point to the extremes of this where we teach and train our armed forces, special forces people, basically to be shot, have no emotional contextual aspect of that. They have pain, but they suppress the emotional contextual aspect of the pain, and they continue the mission until they finish, at which point they can then work through the emotional aspect, which means that we can do this backwards as well. Probably not to that same extreme, but at the same time, just thinking about how the mind changes the perception of pain and can increase or decrease it. We recognize that for any patient that we see, there are always confounding variables about cause and effect, and these things can be anything from early life trauma, superimposed mental illness. Generally speaking, you're going to see a lot of anxiety-related disorders in the typically a younger addicted patient population. Social instability, meaning they don't necessarily have family or friends that they can count on, that they can identify, that they can walk through, and really at 2 o'clock in the morning, pick up a phone and call somebody and get help. The familial predisposition is definitely problematic. I mean, genetic predisposition is probably 50 to 60% of the risk. And then the current healthcare system, which is just kind of broken and relatively fractured, especially if someone is requiring help with Medicaid and trying to identify a continuum of care for someone with a substance use disorder when they are uninsured or underinsured becomes really problematic. And then when we're thinking about pain in general, when we get into this, what is the goal? What is our goal? Our goal is not to get rid of all of the pain. And this is important because we generally can't. If you have an injury, if I've herniated a disc in my lower back and it's compressing a nerve root, I can give you physical therapy. We can do some injections. We can get you some cognitive behavioral therapeutics, mindfulness-based cognitive therapy, and I can get the pain controllable so that we can ultimately increase your function. But what we've done for the last 2 decades is basically just give somebody an opioid to make them forget they even have pain. And they got used to that. We got used to that. And so people have an expectation that if I have pain, I should be able to get, quote, something for that pain. And what they mean is a quick pill to be able to take that away. And that's a very American trait where we just assume that what we should be getting, if I have something, I need to get something now. And generally speaking, we feel that that's a form of a pill. If we look at the structures in the brain that are responsible for pain and addiction, they're pretty close. They mostly overlap, with the exception of this area, the multicolored area here called the thalamus, which is really just a relay station. The rest of these structures are required as a component of the development of addiction, but also the stabilization and the treatment of pain. And so there's a lot of overlap. And we really threw a wrench in that when we started adding large amounts of opioids to the system, because the body didn't know what was going on, and it began to really confuse the treatment of pain with the stimulation of the central reward part of the brain that is responsible for addiction, and turned people who had pain into somebody with a reward function disorder or addiction. And it started with pain behaviors and all of that around it. So let's dig in a little more about the neuroscience. So I'm gonna be pretty deep on this, and I think it's important. In the past, I used to be really superficial on this, but then I recognized that everybody's pretty smart, and you can take this on and really understand it. And so I want to dig into these specific things to show you how complex the pain system is, so that we know that it seems almost silly that we would give somebody just a medication and magically pain would be better, when we're trying to modify with a volume knob a really sophisticated, intricate system. And so there's the way that we figure out that pain is coming in, and those are called the ascending tracks, which means I poke my finger, I get a signal that goes in my arm, it goes into my spinal cord, into the dorsal horn, and then goes up to the brain. And that one is basically the spinothalamic or cervicothalamic tract. And this is the really important one that localizes that pain. It goes through the thalamus, it goes up to the part of the brain that says this is where I have pain. But at the same time, it also turns on this one called the spinal reticular tract. And the spinal reticular tract is really important because the reticular activating system is the part of the brain that's responsible for arousal and sleep-wake cycles. So if you roll over onto something painful, I have a shoulder injury that bothers me off and on, and if I roll over on the wrong way, it wakes me up because it says, I don't want to do that. Well, this is that pathway that gets there. It's the spinal-reticular pathway. And then the spinomesencephalic pathway goes to the periaqueductal gray and then on to the amygdala, the emotional portion of the brain. And that it really gives us the emotional context of the pain. So this is where we have someone who cuts their finger, sees a little blood, and some people freak out like the world is ending and their whole hand was cut off, but it's a paper cut. Or we have someone who basically, like the soldier who gets shot, and they're like, oh, it's just a flesh wound, and they move on. So what's responsible for that is the spinomesencephalic tract. And interestingly, that's the tract that we can manipulate the most with therapy and therapeutic, contextual approaches to that pain. And then the spinohypothalamic tract, and that's the endocrine response, and mainly the fight or flight and cortisol-like responses that we see with chronic pain and even chronic trauma. So if you look at each of these, spino-reticular, spinomesencephalic, and spinohypothalamic, those three areas that they go to in the brain are also irritated and turned on in the same way with chronic trauma. So again, there's a lot of overlap between addiction, pain, and trauma, which is why the waters get very muddied in these patients. So if we look at what happens here, and you twist your back and we get this signal that comes up, it goes to the dorsal horn, it comes up to the reticular formation, which is the reticular activating system, and that's the one that wakes us up. It comes all the way up periaqueductal gray to the amygdala, and the amygdala is our emotional brain, and then it comes up to the thalamus and goes here. So this is the spinothalamic tract, spino-reticular tract, spinomesencephalic tract. And if I added the spinohypothalamic tract, it would basically just scooch over here and go up to the hypothalamus. That one's pretty minimal for what we're dealing with, but it's important to know that for every piece of pain that I have, every time I twist and hurt something, all of these things are getting tweaked in the brain. You're getting the signal that goes up all the way through. So that's the gas pedal. That's the thing that's sending the signal up. So what happens to try to modulate that pain coming back down? Well, we have descending tracts. And those use the gamma-aminobutyric acid system. So the same one that benzodiazepines work on or alcohol works on. And they all start kind of in the periaqueductal gray, but they go to a little bit of a different pathway. So the periaqueductal gray goes to this area called the locus coeruleus. And I know I'm throwing a bunch of terms at you, but again, it's important to understand that we know this. We really understand these systems really well. And the locus coeruleus is important because it's the part of the brain that makes norepinephrine, adrenaline, and releases that. So it's important not only for pain signaling and as it goes down to the dorsal horn and trying to decrease that pain, it can also increase that pain if we decrease that norepinephrine response. So it can go either way. So this one can either put on the brakes or lift the brakes all the way off for pain. But interestingly, that same norepinephrine in the locus coeruleus is what's out of control in opioid withdrawal. So if somebody stops their opioids, you get this massive release of norepinephrine from the locus coeruleus, which causes about 95% of all of the things we see in a clinical opioid withdrawal scale. And one of the main things that they complain about is pain. So it's important to understand that too much of anything is bad and too little of anything can be bad. Periaqueductal gray, this goes through the raphe magnus and down to the dorsal horn. And this works through the 5-HT2 system, the serotonin system, and the enkephalin system, which is our own endorphins. And that works to go down and decrease the pain. So we have all these things that come up. We have two pathways that come down. And if we look at these correctly and we say, all right, so one of my descending tracts, we go to the locus coeruleus, I bump up some norepinephrine a little bit. It goes down to the dorsal horn. That changes the pain signal and decreases it, so less gets to the brain. That also starts to make sense of why we would use something like a serotonin norepinephrine reuptake inhibitor, right? If we use an SNRI for pain, this is one of the mechanisms that it's augmenting. It's increasing the norepinephrine so that it's basically increasing the chances for this signal pathway to work better. If we look at the other one and we go from, the amygdala down to the periaqueductal gray, we create an endorphin pathway that comes to the raphe magnus, which releases enkephalin and can release dynorphin as well, and comes down to the dorsal horn, also decreasing pain. So when these turn on, it decreases the total signal that can come up. So if I didn't have these, then I would have a signal that's unabated going up to the brain and going up to all of those other places. But if I have a positive disposition about the pain, or I'm using mindful approaches to the pain, then I can make my amygdala send a signal to the periaqueductal gray to release endorphins, which then goes to the raphe magnus, which then changes that into a different signal with using serotonin and enkephalin, and then comes down and then decreases the pain down here. So this is the track that is so important that we try to work on when we get a person to focus on a positive thing, or to be mindful, which is recognizing that there is pain but allowing it to pass by. This is where the behavioral therapeutic pathway works the most. So I always get, when I talk to students or a lot of people, like, well, who cares? Why does it matter that we know this stuff? Because we manipulate these things all the time. And if you look at just opioids, we're manipulating the periaqueductal gray, the ventral medulla, the dorsal horn, a number of other places as well. But in serotonin, we're manipulating the amygdala and the raphe magnus. Norepinephrine is manipulating the locus coeruleus. And so if I give you an SSRI, then that's changing the serotonin axis. If I'm giving you an SNRI, that is norepinephrine. If I have chronic fight or flight, like I live in a really high risk environment in my household or in my neighborhood, that's getting more and more norepinephrine on a daily basis. And so that changes the locus coeruleus. So there are a lot of things that go on in this very dynamic pathway. And GABA is important because I talked about how that one pathway that goes down that we can control can release enkephalin. Well, enkephalin inhibits GABA, thus allowing the release of all of these things above. And so if we take off the brakes, we allow for this to work much better. And that can be helpful. And then benzos or alcohol work on the descending pathway by inhibiting it. So those two things together, if you're taking those, can actually make your pain worse. And so we have to start looking at all the different ways that we manipulate what's supposed to be a very sophisticated system. And it's like taking an equalizer that's supposed to be fine-tuned and taking all of those and just cranking them all the way up to the highest level. So let's talk about what happens when somebody has a normal pain response. Let's put all this to work. So let's say Kayla pops a disc in her lower back. She's the third trimester. She twists wrong or sits hard, and she laterally herniates a lumbar spine disc, and it compresses her nerve. So she gets this acute pain. She emotionally assesses, and if everything's good, meaning she's like, all right, I can deal with this and my life is not in crisis and things are okay, then we get an increase in this descending inhibition, all of those descending pathways, and then we decrease that ascending pain signal. So we're blocking the signals coming in from the back that are going to the brain. So we're basically trying to cover it up. And this is happening, and we're producing our own endorphins from the periaqueductal gray and the dorsal horn. We're making our own opioids. So this ultimately allows for what is lower pain and improved function without one drug ever hitting the system. And this is an important aspect, because if we allow for this to happen over time, the body can modulate pretty significant pain until we start messing with it. So what about somebody who has, quote, a low pain threshold? Well, there's a backup system to this. And so let's say they have the acute on chronic, same thing. She twists her back, pops a disc, and she emotionally assesses, and it's not good. She's freaking out. She's basically Kayla. She's got no help. She's like, well, this is like the last thing I need. She's, just completely becoming histrionic and not really able to be, consoled for this. She gets an increase in the descending excitatory pathway with this. So it's actually sending more signal down instead of blocking signal. She gets a decrease in the inhibitory pathway, which means that we're not blocking any of those things coming up. And then she has kind of hysteria, which turns into tachypnea, which is a panic attack. And so she starts and doing that. Well, the interesting thing is the backup system for when these systems are out of whack, because of the emotional contextual aspects of pain, changes the pH in the serum. Now we know that if you breathe off too much, that you can actually get your hands, or you get this carpal pedal spasm, where you'll see people, because they blow off so much carbon dioxide and their blood gets alkalinic. And so when that occurs, well, this starts to occur. And when it hits a certain pH, then you get an automatic backup release of endorphin. So endorphins will be released from the periaqueductal gray and zone 2 and 3 of the dorsal horn, which means even though the normal systems aren't working, our backup has kicked in and allows for us to dump those endorphins into the places that they need so that we can now get pain control. So even somebody with a low, quote, threshold for pain, that kind of, tachypnea and increasing hyperventilation acts as a trigger to help the body to have another natural pathway to help take care of this. If we go to a person who we've added opioids to, this is where we start really wrecking the whole system. And so we get, as a baseline, if you start somebody on opioids, you get a decrease in natural opioid production because the brain says, well, I don't really need this. So when the opioids come in and they bind to the mu-opioid receptor, that sends a signal, a feedback signal, and says, all right, I'm good. I don't need any more. So your body decreases the production of its own endorphins in the periaqueductal gray and the dorsal horn. So you're not able to make your own pain medicine much anymore. But the body doesn't like that. And so what it does is it ramps up the pain intensity because it's like, I need to get this signal through and I'm not able to. So it just cranks it up. So you get a greater signal from the ascending tract. So all of those, not just one of them, not just the spinothalamic, the one telling you where the pain is, not just the spinal-reticular, the one waking you up, but you also get it in the spinomesencephalic, the one creating distress, and the spinal hypothalamic, which is cranking up things like cortisol in the hypothalamic axis, that can be really problematic for long-term endocrine balance, especially for risk of type 2 diabetes and increasing blood sugars for those patients, changing the way in which we metabolize food. And so we'll see people that have chronic, poorly treated pain slowly gaining weight, and it's the way in which their body shifted that, and that goes to that hypothalamic tract. Pain gets more intensity and in a widened area. And this is important, like hyperalgesia, where you go to touch somebody and they react to a non-painful stimuli, like you've given them a poke in the back with a hot stick. And then also when we're turning all of this on and we're cranking these signals up in the spinal reticular system, when that happens, they don't really get good normal sleep. So you create a sleep disorder. And I'm sure many people on this phone have been sleep deprived at some point. And during that sleep deprivation, you've recognized you're not yourself. You get a little irritated. You snap back a little more. You aren't really able to do math as good as you wanted to. You're not really able to remember things like you want. But people in chronic pain, because of that constant pinging of that spinal reticular tract, they have that over and over and over and over again. And so because of that, you get a chronically sleep deprived person, no matter if they, quote, went to sleep last night and slept because I took 2 extra Valium, they're still not getting good sleep architecture, meaning they're not getting all the stages of sleep that they need. And with that, you get more emotional ability from the opioid effects in the limbic system. So we already know that the opioids start to affect the emotional centers in the brain and the way that people behave. Well, when you add sleep deprivation to that, it worsens it even more. So we've really set this person up to fail in this situation. And if we look at this, we've turned on all of these signals and they're just super intense and they're cranking up in all of these areas. And one of the biggest problems is we've now turned this up and we've discombobulated the entire normal system. So what happens to the backup system with this one? So if you have that pain and you emotionally assess and all is good or not good, it doesn't really matter if you perceive positive or negative after you've had opioids on board and you popped a disc in your back. You still get an increase in the descending excitatory pathway, which means that we're not putting the brakes on anymore. So that signal is going down and saying, yeah, this is something we probably need to worry about, and cranking up the signal instead of putting the brakes on it. And then you get a decrease in the inhibitory pathway, given the presence of the opioid, meaning that the periaqueductal gray is not producing as much endorphin, and the dorsal horn is not producing as much endorphin. So this increases the perceived pain followed by hysteria. The problem is when you're on a chronic opioid, you block the respiratory rate increase. So we always worry about an overdose of opioids causing respiratory suppression to the point of somebody not breathing. But taking them on a regular basis can also act to block the tachypnea, that increase in the respiratory rate that we would want, in order to change the pH to help dump some endorphins into the system. And that doesn't occur here either. So you have this panic state, and then the pain continues. And in many cases, it widens in intensity because the little bitty nerve endings in the side are now all getting agitated and turned on. And so now what you have is somebody who may have a pain of something about that size that now turns into this massive my whole back hurts, my whole body hurts, my whole arm hurts, when it's one spot that's injured. So we could have looked back and figured this out. This is not brand new science. I mean, we've known a little more about it now than we used to, but at the same time, most of these basic concepts were known. And so the addition of opioids to begin with, create a really problematic setup for normal physiology to just not work. So if we get a person who has been on heroin and oxy, all of the above, and we come in and we get them stable on medication-assisted treatment like buprenorphine and methadone, those have a tendency to allow for the pain system to recalibrate. And that's because of the way that they work. Buprenorphine, because it's what we call a partial agonist, meaning it doesn't turn the mu opioid receptor all the way on. And methadone, because it's not only an opioid, but it also has these effects like ketamine in the dorsal horn. So it can also help to re-equilibrate that, different than the other opioids. All right, so that was, I have to tell you, that was more pain neuroscience than the vast majority of doctors get throughout their entirety of training in medical school and residency, all the way through. So if you want to just watch that a couple of times and get that down, those are the basic concepts. It's for every kind of pain, whether we're talking about inflammatory pain, neuropathic pain, or even central pain. The same pathways exist. It's just different chemicals causing the pain, pain signal. So just knowing what those pathways are, where they go, and what they do can be really helpful to understanding what you're seeing in front of you, and actually help you have a little more empathy. I mean, I still see a lot of patients in the emergency department. If I do a number of shifts in a row, it gets tough sometimes to maintain that empathy. The empathy tank is empty, or the empathy train has left the station. Either way, at least understanding the science can really help you to recognize that they're not here just to game you. They're having something going on, and whether it's suffering or actual pain stimulus, either way, there's still brain structures responsible for those that we need to identify, and then we need to help stabilize. So now that you know everything there is to know about the neuroscience of pain, let's get into some real, like, what do we do now pieces. And I want you to think about Kayla in a sense, and I'll talk a little bit about Kayla when if she didn't have anything on board, like she wasn't on buprenorphine, and then I'll talk about it if she's on bup or methadone or naltrexone and what she would do. But I think it's important to look at how we're going to treat post-operative pain, and this could also be post-injury pain. So somebody's in a car accident, somebody breaks a leg. You can take portions of this and parse it out to that as well. So again, we come back to let's make sure we know what problem we're solving. And so, we're not trying to completely eliminate post-operative pain. We are trying to eliminate the risk of relapse, but I think it's really together where we want to manage post-operative pain while reducing the risk of relapse. It has to be a combination of two, because if you don't treat the pain, risk of relapse is huge. If you over-treat the pain, risk of relapse is huge. So you need to make sure that we appropriately treat the pain, not overdo it or underdo it. This is a Goldilocks phenomenon. It's got to hit, exactly the right pathway. So the common concepts to this, and this has to do with, quite honestly, anybody on MAT, anybody on chronic opioids for another condition, or just anybody walking into the operating room and understanding what we would do if somebody comes in. And now some people don't take opioids. They don't necessarily have chronification of pain. They have a stable mentation and their emotional ability is fine. And so pre-op screening is going to be quick, right? Pre-op treatment for pain. If there's no meds, then you really don't have to do a ton of pre-op. We'll get into a little bit of things that can be done. And regional anesthesia is plus minus. What that means is if I put a little catheter in and I block the femoral nerve because I'm going to do something on the knee or the hip, or I do a brachial plexus block if somebody's going to have shoulder surgery. Those really do help to decrease postoperative pain and increase effective function more quickly and decrease the need or request for opioids. What you do inside of the operating room is important as well. So intraoperative treatment, postoperative long-acting medication, patient-controlled analgesia, short postoperative prescriptions. These are all basic concepts that really there. And so people who have a high tolerance for pain medications, and we talk about what that looks like. So we had somebody who has a low pain tolerance, but somebody who's been on chronic medications and now has a huge tolerance to opioids, we'll get into in just a sec. And I think that's important because a lot of these patients would be like, well, 5 milligrams of oxy is not going to touch me because I was doing, a dime bag of heroin every 3 hours, or my doctor was prescribing me 200 micrograms of fentanyl, for that. And I've seen stuff I never thought were humanly possible. My 115-pound female patient who was on 600 milligram morphine equivalents prescribed by a physician, for Ehlers-Danlos, which is not by itself a totally painful condition. And so there's stuff that is crazy, but most people are going to have a medium to moderate tolerance. And so if that's the case, it's about the same as if you have somebody on MAT, because if you're on buprenorphine or methadone, you are going to increase your tolerance to opioids because you're on a chronic opioid, even though they act a little differently and they do something different. That increase, changes the way that the body perceives it. So they're going to have at baseline a little bit of a decrease in the endorphin production. They're already going to have a little more intensity in the signal from wherever the injury or surgery is occurring. And so that has to be kept in mind as we're doing this. And this is why I always say if somebody's on medication-assisted treatment, that's not pain treatment. That is their new baseline. So when people say, well, they're already on methadone, so I don't need to add anything, that's not true. If they're on methadone, then they're on methadone, and that's their baseline. So they still need that dose plus what we treat them for pain above that. And if you have them and we're going to be doing a surgery, or we know that we're going to have something that may have complications, in a perfect world, and I recognize perfect worlds don't exist. I've worked in the Medicaid world. That's been my entire world for my life. And so to get all of these things lined up for a Medicaid patient who has bad transportation, poor communication via like telephone and difficulty in interaction, to one schedule and get these done is a Herculean effort. But if you can get them done, it really does make the outcome better. So having a pain specialist consult someone to make sure that there's a good preoperative plan in place so that we know exactly what's going to happen, and they know what's going to happen so that it's not a surprise. Every effort should be used for these patients to use regional anesthesia. So lidocaine, ropivacaine, bupivacaine, whatever you need to do to block that nerve or the nerve field around where you're doing the procedure is really important. This also goes for if they had an injury and they come into the hospital. So we see this in the elder population where they're on chronic opioids, and they come in, they fall and break a hip. We come in, we'll do a regional anesthesia in the ED now, right there. We'll just do an ultrasound guided block, and then they're all good. And then also make sure that we're doing preoperative anesthesia consultation with them, meaning before they show up for the day of surgery and whoever happens to be working that day pops to the bedside, most anesthesia groups have the ability to do either a telephonic consult or a face-to-face consult for more complex procedures or for complex patients with simple procedures. So identify what that mechanism is. And the data is pretty good for showing that mindfulness-based training, 2 hours of mindfulness-based training in now 4 studies showed a significant decrease in the need for utilization of opioids post-operatively by almost like 30%. So it's worth it. So intra-op, if anybody here is PACU or works in the, anywhere around the operating room, generally for patients with high tolerance or on MAT, utilizing intraoperative ketamine and lidocaine, really helpful. Those medications have been found to be very safe and very effective for helping with pain, and they don't utilize the opioid pathway. So it doesn't ping off the reward center of the brain. And then all preliminary medications should be dosed initially in the PACU, meaning that when they come out of the surgery, many times what's happening is they're still pretty groggy from all the stuff that they got inside of surgery, and they're waking up. Well, then they start waking up. We make sure that they're awake and alert. We pop them on a monitor. We take them to the floor. They haven't gotten their meds yet. They now get to a floor. Now they got to be seen by somebody who's taking them from the PACU to the floor, and they do their introductions, and they do all their physical exam, and they do their charting, and they make sure the bed's set up, and they do blah, blah, blah. Well, by then we've now gotten behind. By then we're an hour and a half status post IV pain medicines, because they haven't given them oral pain medicines in the PACU generally. Generally speaking, they're just doing IV push, and that IV push lasts for 30 to 50 minutes, depending on what they're using. And because of that, you get behind very quickly. And then all of a sudden they're on the floor. And then if we have, 1 to 2, 5 milligram Norco, PRN every 4 to 6, blah, blah, blah. And we give them one, and then we give them another, and then we can't give them another, then we're behind. So making sure that the initial dose of pain medication is dosed in the PACU, so that by the time that they get to the floor, that's already settled in. And as the IV stuff is wearing off, the PO stuff is now doing well. Or patient-controlled analgesia if they have a PCA. So what about the non-opioid piece? So that's really the opioid stuff, but there's so much that has good data on it for what we should be doing for these patients post-operatively for this. And so acetaminophen actually works. The IV acetaminophen does seem to work better for post-operative acute pain. It seems to really do a little better with blockade at the central neuroaxis. Celecoxib can be given immediately post-op. So right as they can take something PO, I recognize that post-operatively some people are vomiting. So as soon as you can get them something PO to get absorbed, if you're not going to use the celecoxib, and the reason I picked celecoxib is because that was the drug that the original studies were done and then shown to be effective and redone on. But you can also use ibuprofen or ketorolac IV. Those are helpful as well. Oral ibuprofen doesn't seem to be as effective as celecoxib or ketorolac IV, but IV seems to equilibrate it out. And then also gabapentin for TID for neuropathic pain. So anybody who had a surgeon slice through them is going to have some version of neuropathic pain. Orthodox are now looking at gabapentin as one of their mainstays of medications post-operatively, where they'll dose them with celecoxib, gabapentin, and use a lot of lidocaine intraoperatively. And that's becoming just more commonplace that we see it. Utilizing ketamine either through a drip or 48 hours for up to 48 hours after surgery can be really helpful. And this isn't 3 micrograms per kilogram per minute is low dose. They're not going to be whacked out because of this, but it's enough to get that dorsal horn to work. And you can use lidocaine up to 2 milligrams per kilogram per hour. So you can actually give IV lidocaine, and that one has plus minus data, but it's still effective and safe at that dose. And if you got a little something else, a little salve, you want to rub on that, then so be it. But whatever really it takes to get them there. All right, so what if I have a patient with buprenorphine and they come in and they've been on bup and they've been on MAT? First, how are we gonna talk to them? Remember, we have to say, what are our goals? Our goals are not to have them pain-free. It's to have them pain tolerant. It's to keep them functional so that they can move there and decrease their risk of relapse. So we have found absolutely you should continue the buprenorphine. If they don't want to take other opioid medication because they're scared to death of it, which I would think a lot of them are, then you can go to 8 milligrams 3 times a day. And if you do that, that actually works really well for pain. If they're post C-section, you can use a fentanyl PCA for 24 hours. So you can put them on, fentanyl does a really good job of working above buprenorphine, and you can put them on a PCA so that they're in control and you're not having to go get bedside IV push doses. And then the biggest one is, sorry, take a break, breathe. We overcomplicate this way too much. We always make this way too complex. Maintain their medication, increase that. If that doesn't work, then we can add something on top of it. And then always use the totality of your non-opioid medications. That should just always happen. Those should be the order sets. And that's the fastest way you change anything in a hospital is you change the order set. What about if they're on methadone? Again, if Kayla comes in and she's on 120 milligrams of methadone, we would continue the methadone at 120. That is not her pain medicine. That is still dosed single time per day. Don't use more methadone for pain control. It is not an acute pain medication. It takes 4 to 5 days for it to peak in its dose effect and can be really dangerous for these patients. You definitely want to use all the other non-opioids. You want to, augment with typical opioids if you have to, meaning if you have to add another opioid, you can just use hydrocodone, and that's fine. And but instead of 5s, you may need to bump to 7.5s or 10s to get that. And then if you're going to have to give a prescription when they leave, it's okay, but you make sure and contact their opioid treatment program first, because 2 things will happen. One, that's really sending someone with an opioid addiction home with a prescription for opioids is always risky. It's risky for them. It's risky for you. And for more than one reason. So if they take all of them in overdose, that's obviously a big issue. If it causes a spike in their reward system and causes relapse, that's a problem. Also, if nobody knows about it and then they show up at their OTP and they have a toxicology test that's positive for hydrocodone, and they're not supposed to, then they run the risk of getting booted out of their treatment program. So it's really important that communication takes place with that. What about naltrexone? Naltrexone is the medication. It's a long-acting injectable. You can also take it orally. It's not really good for pregnant patients, mainly not because it's not safe for the fetus. It seems to be perfectly safe for the fetus and for mom. The problem is it does block the opioid receptors, and so it makes it more difficult to treat pain. And so if you know you're going to have to deliver a baby and you're not sure, you probably don't want that sitting around in the 3rd trimester when you're getting close to delivery, because that really limits your options of what you can do for pain. However, if she's not pregnant and she's just on her own, then you can use the long-acting injectable, wait for 30 days post-injection. If they're taking oral, you want to wait for 7 days before you do it, and use all non-opioid pain medications. And then ketamine is your friend. Seems to be a scary medication for a lot of people. It's super not scary. It really is an effective medication for the treatment of this. All right, so that's kind of the post-op piece. So before I jump into these other things, I think it's important to talk about, the conversation, like how you're going to talk about this. So one of the biggest fears the 2 biggest fears that patients with an opioid use disorder on MAT have are, one, that they're going to show up at the hospital and not get their pain treated. That's a huge fear. And the other one is withdrawal. So we want to make sure that when we have these conversations that we're saying, look, I just want you to know, Kayla, that we're going to make sure that you don't go through withdrawal. We're going to make sure that you have an understanding of what's going to happen. We're going to write it down. I'm going to send it to your surgeon, and I'm going to send it with you, because we all know some gets lost in the fax or in the mail or in the electronic health record. So we just want to get it there. We wrote pain treatment birthing plans for all of our patients, and I had a peer support person who, every time that somebody popped to the hospital, they would walk a copy to the hospital to make sure that it got there, and or we would fax it if it was another hospital. To make sure that even though we knew it was in the EHR and the patient had a copy and the OB-GYN had a copy, You just want to make sure that that gets there, and letting them know that you got their back on this becomes really, really important, because they're scared. And with all the things that Kayla had with early life trauma, and she's got no help, and she's, nobody in there to really support her, it really becomes our job. And it becomes our job to do that, not just by treating her pain, but letting her know that we're aware that this is scary, that we're aware that we need to work on this, and that we're not going to let it fall through, and let her say back, ask her, what are the things that scare you the most about this? Like, what are the things that really are worrying you? And then answer to those and make sure and deal with those. For the patients who are not quite stable, and they think, and you might think that they're going to try to get there and try to maybe get some more pain medication and that, these are people that we set boundaries for pretty early and say, look, here's what we're going to put forward for you. We're going to put forward a plan. The plan is not to use random opioids for this. That is the biggest risk for you. We can add more buprenorphine. We can use some other things. And if we have to give you an opioid, it'll be through a patient-controlled analgesia. So you'll have control, but it'll be delivered in a way that's not dangerous. And we're going to do these other things. And then just know that you need to be available. If you're an outpatient treatment provider, that you need to be available for them on the phone if they're going to call, after hours, or I'm in the hospital, so that they don't escalate to the point where they're asking for something because their pain behaviors have gotten a little bit out of whack. They haven't slept well. They're freaking out. They're scared to death. And they don't feel like they're getting adequate pain control. And the vast majority of these patients are also not exactly treated with the red carpet treatment when they show up to the hospital. So we have to worry about stigma. And then if there's someone of color, then not only is it the stigma of addiction, but then the added structural racist aspects that live and breathe inside of the walls of a hospital on a regular basis. And so making sure that they feel supported through each of these pieces is important. And it's actually, to them, more important than what dose of what med. And as long as you have a good plan and they're a part of that plan, they do pretty well. The ones without support, we make sure and give them a call while they're in the hospital. We call their nurse, do that. It's a little extra effort, but it becomes really important for that. And whether it's a family member or a peer support person or community health worker out of the clinic, it doesn't really matter, as long as there's that connection point of, hey, we got your back. We know that this is going on. And you can also, and my patients, they all, by the time that we finish their, well, you don't ever really finish addiction treatment, but the time that we can, got them very stable and they were very independent and not requiring too much of us, we spent a lot of time talking very much about what we're gonna do with their meds and this. We spent a lot of time teaching them about the neurobiology, and so my patients knew about the spinal thalamic tract. They knew that word. They would say it. They knew about the dopamine release in the nucleus accumbens. They knew it's okay to teach them the real science. And in fact, most people appreciate it. They'll tell you, like, I don't care. And that's fine if they don't. But a lot of people really want to know, because it gives them another sense of control and another sense of well-being to really have that. So I'm going to dig into this piece, because I think that this is something that we should be doing a lot more of, especially in patients on medication-assisted treatment. And again, for those who came on late, I started with, I'm a neuromolecular biologist, and all of this stuff I was pretty skeptical of, and still am for some of them. But I felt like, to give it an honest shake, we would go through the data that's out there for it. And I will let you know that I now use the vast majority of these things with my patients on a pretty regular basis, and on myself when I have surgery or injury. So these things can work, but it requires us being confident in it when we talk to the patient about it, and not being like, we could always do hypnosis. It's not going to exactly get the patient on board for what you're going to do. So let's walk through first what the differences are that we talk about. So we talk about conventional medicine, and that's, MD, DOs, PAs, nurse practitioners, this, pretty standard delivery of medical care, right? This is the allopathic model of care. Complementary medicine is when we have some things that we add to conventional medicine to enhance the outcomes. So like osteopaths will add manipulation. There are things I trained in Philadelphia for residency, and we actually had a Chinese medicine admitting service. Now, they used mostly allopathic approaches to treatment, but they would add pretty consistently things like acupuncture, Reiki, and things like that, but never at the behest of the mainstream medical care. It was always added on to. So that would be complementary medicine. And then we have alternative medicine, which means that I'm not going to give you an antibiotic, but we're going to drink these things and take these things and do these things. Or I'm not going to give you a pain medication or do an injection, but we're going to do this, that, and the other. So those are, that's different. And then complementary and alternative medicine, you'll hear commonly the term CAM. And they're lumped together, but they really are different, especially if you think about it in the way of alternative medicine is there to supplant conventional medicine, where complementary medicine is exactly what the word said. It's there to complement conventional medicine. And I think that's the way that we're going to take these things with good data and slowly get them into the mainstream of medicine for both buy-in of the professionals delivering care, but also the people paying for care. So the NIH has a classification within the CAM, the complementary and alternative medicine sources, and this is mind-body medicine, and so that includes things like hypnosis, biofeedback, guided imagery, meditation, spirituality, cognitive-based mindfulness. Is the same basic thing. Biologically based practices, so this would be herbs and supplements and aromatherapies. We have alternative medical systems, which would be homeopathy, traditional Chinese medicine, Ayurveda, and naturopathy, neuropathy. And then we have the manipulative or body-based practices, massage, chiropractic, craniosacral, yoga, and energy medicine. And this is how the NIH breaks it out. Neither here nor there, but it's important to know that this has been looked at systematically. So when people say they just don't want to use it because they don't want to get, they want their money for this, it's not that we're not looking at it. We're trying to really look at all of these things so that we can make sure and add on whatever we can. And once we get enough data, then we can finally get these things paid for. And so if we're looking at patients with chronic pain, so let's say we're looking at the later life Kayla, where we missed everything and now she's got chronic back pain and it hurts everywhere. She can't really do much of anything. And it's associated with ongoing nerve damage, inflammation, spasms. It's far past the time in which she ever had an injury. And a lot of times is directly connected to emotional learned behavior issues and central chronification, meaning that the signal is not coming from the back or the disc. It's actually just regenerating in the spinal cord, in the dorsal horn. It's just spinning here, or it's a signal that's a memory signal sitting up in the periaqueductal gray or the thalamus, continually popping off this pain signal, even though the location of pain is fine. Now the brain, the person having this, their brain will make it feel like it's coming from their back, but it's actually just being pinged from a pain memory that's sitting in the brainstem. Dr. Joe Apkarian at Northwestern has done a lot of good work in this stuff, and it's a little out of the scope of this conversation, but people can have pain, and we can have completely negative studies, but they're having pain, and that pain is just being generated centrally in the brain, and it got kind of locked in that pathway, and that's where we're finding things like ketamine can be really helpful because it kind of unhinges that pain memory. So what we know about just the medications that we use is that NSAIDs and acetaminophen are as effective as opioids at 6 months. And in fact, there's new data to show that they're as effective as opioids at day one. As we did larger studies for minor to low moderate surgeries, patients in the control group where they were given acetaminophen or hydrocodone with acetaminophen at 12 hours post-operatively, same outcomes. And so it really means that for moderate and severe pain, not much is really helpful. And opioids may make the pain worse and can increase the risk of all of these other aberrant behaviors and risk of hyperalgesia and or addiction. And then obviously just the risk of accidental or purposeful overdose that comes with that. So if we look at mind-body medicine and, these things, the hypnosis, biofeedback, guided imagery, meditation, and relaxation training, hypnosis is kind of this altered state of awareness within which, people experience a heightened suggestibility. So interestingly, this has obviously been around for a long time. And if it wasn't for the gimmicky people trying to do hypnosis to make people walk around like chickens, it probably would be a mainstay of medicine, because it is one of the few ways that you're allowed to create introspection if done properly. And I love this picture. This guy just creeps me out. And I almost like get hypnotized just looking at this guy's hair. But if we look at biofeedback, we look at what it is the skin temperature, heart rate, respiratory rate, galvanic skin response, EMG, heart rate. And then the tool is we measure that, and you see it, and you try with your brain to manipulate that output. So you try to manipulate skin temperature by thinking about it. You try to manipulate heart rate by thinking about it. You try to manipulate your EMG by thinking about it. And it's interestingly successful for some. Some it's not. We'll dig into the data in a second. But it's definitely still used on a pretty regular basis, especially for professional athletes. It's used a lot. So what about the outcomes for kind of this mind-body stuff? So if we look at the Cochrane stuff, 28 trials, 1,951 participants, the largest effect sizes for treatment versus control. So if we're looking at the things that had the biggest difference, and this is for hypnosis and biofeedback, is distraction. So self-reported pain, meaning they're not reporting as much pain because they're distracted by whatever they're doing. And that's fine. And it seems to be long lasting, interestingly, because if you start to feel the pain again, then you can take yourself back to that memory of thinking about it and continue to have that. So they do seem to be able to distract themselves from the painful stimuli, and it's with an appropriate p-value. And then hypnosis has a decrease, not a biofeedback, but hypnosis by itself is a decrease in self-reported pain, a decrease in self-reported distress, and a decrease in behavioral measures of distress. So when we really do measure it out psychometrically, and we can identify that, and then combined cognitive behavioral interventions, if we do all of these things together, other reported distress and behavioral measures of distress are all decreased. And that was the Cochrane of 2006. It's been repeated. They're putting a new one out now. And I talked to the people working on that, and they said it's only going to strengthen these relationships, the one that should be out by the end of this year for that. But we also have some hypnotherapy specific things. And they looked at a meta-analysis of 13 studies that excluded headaches, but they looked at other chronic pain. And it basically showed that hypnosis significantly, meaning was more effective than a control. And control was care as usual, meaning getting meds, doing PT, the normal stuff. And then on top of that, they added hypnosis and confirmed for a wide variety of these things: cancer, low back pain, arthritis, sickle cell, TMJ, disability-related pain. And it over and over again, it was shown to be helpful. So it's not, if it wasn't for the hokey stuff back in the 60s and 70s on the shows, I think quite honestly, this would be integrated more effectively into the treatment of what we do. And then this one was really interesting. So this meta-analysis looked at 25 trials and for hypnosis and its inclusion for psychological reaction versus placebo. And so they had a medication that they gave them versus a placebo medication. And then they had a medication, and then treatment as usual or wait list. And so the chronic pain or other cancer pain, pain and disability or emotional functioning, all of those improved. And honestly, once they were taught it, self-guided versus therapy-guided looked pretty good. And then that large positive effect in this study was for all of those elements, for post-treatment and follow-up. They had some small, non-significant effects for disability and emotional functioning, but all techniques produced significant effects on pain reduction. So every way that they tried to apply the hypnosis significantly decreased it. And then self-administration versus therapist-administered interventions had similar effects on pain reduction, which is great, which is like this mindfulness-based cognitive therapy. So you can train people to be mindful. And when you train people to be mindful, they can do that themselves whenever they're starting to feel stressed or have pain. And last I checked, you're not going to overdose on mindfulness-based cognitive therapy. I mean, you might be like, wow, man, this is awesome. You might hit spiritual relevance or something, but that's it. And so the questions always come up, like the one that's posted here, which really talks about what do you do with people on MAT who had severe trauma? Well, people with severe trauma, I mean, those are people that we do directed EMDR, eye movement desensitization reprocessing, if it's incident-specific trauma. There are other trauma-based therapies that also work and maybe are a little easier to deliver, but that one seems to be the mainstay. And we were lucky; we had EMDR certified people, so it's like Candyland, right? You know, I live in a place. I just got very lucky that we found social workers who were trained and certified in that. If you're not, it's a really cool thing to do that, to learn how to do that. So that's what we would do for our severe trauma. But mindfulness is also really helpful. Mindfulness is not really harmful for anyone. It's what's kind of nice about it. It allows you to be introspective. It allows you to sit with the moment. It allows decrease basic anxiety. Even if you're sitting in a meeting and you want to throat punch the dude next to you because he won't shut up, and he's like mansplaining everything, and you just want to take him out, give you some mindfulness interventions that you could do so that you don't get a felony for that. So I think that it's important to think about how you can just use this. I use it all the time when I'm having to deal with really, high stress situations where we're doing strategy and we're working through complex problem solving, in places like prisons and things like that. So it's a really helpful thing even outside of treating somebody with pain. What about acupuncture? This one comes up a lot. It's got thousands of years of history. So it's important to understand even if you don't do it, but the data's pretty good for this. So it manipulates specific points on the body called the meridians. Now, interestingly, the meridians also seem to align with the lymphatic and nervous system in the way that the nerves all feed back into core hub dendritic sites. So while they couldn't tease that out and look at it under an electron microscope, they kind of figured it out, what they did. And then the chi ebbs and flows with changes in a person's mental, physical, and spiritual well-being. If you don't know what chi is, if you have children, I have an 8 and a 10-year-old, and we've been in lockdown for COVID for a while, and so they've been at home. So we've watched The Last Airbender quite a few times on Amazon Prime. So I learned a lot about chi there, but it's been used over and over. I've never had it. I've had patients go get it, and I've never had anybody give me a negative response. I've had some people say, I don't really know, and I've had most people say yes. But what does the data show? The data is pretty interesting in this, and you can show that post analysis of following acupuncture, and this is if you do real acupuncture using the meridians or sham acupuncture, it doesn't happen. So if you're doing real acupuncture, you get an increased level of endorphins and calphalins and monoamines, which are direct pain treatment molecules. You get antagonism of electroacupuncture by naloxone, meaning if I give you acupuncture and I put a small electrical charge, almost like a TENS unit, but specifically at the meridian sites, if you do that, you can reverse the pain control that you got from that if you give them Narcan. So it basically is a secondary way of showing it's producing our internal opioids, and we're reversing that with naloxone. And then we have things like functional MRI studies, which look at the brain actively working, and they demonstrate effects stimulating various acupuncture points and the effects on the CNS. And I'll show you a picture of that because it's important to know that it's not just some places, but it's actually mapping specifically to the location where the acupuncture is done. And then the polymodal receptor mechanism, which has been around since the mid-90s, but basically it's that we turn on a lot of the pain receptors, alpha, delta, and C fibers, and we manipulate multiple of those through the location. And specifically because that area is in pain and we go to those areas, you get a higher heightened effect than if you do it elsewhere. But this is really interesting. And as we look there, you can identify the areas that we talked about earlier with the thalamus, the motor area, PG, all of those different locations. And as we look at this, it's not about knowing what it is. It's just kind of amazing that when you look at it, the thing that they say it's doing, we can now see that it's doing it. So if you have a trained, and I saw this over and over when I rotated through the Chinese medicine service, and it's been really interesting that it just doesn't exist much elsewhere. I mean, we had Chinatown was right down the street from where we were, so we had a lot of people coming in asking for traditional medicine. But this is something that we should be just pushing into complementary and then really into mainstream at some point for those with chronic pain, especially now that we know the harm that opioids cause, both short and long term. So what about the safety of acupuncture? If done by appropriate people, you can get about 32% of people that can have some sedation, about 26% will talk about needle discomfort, a little bit of redness or irritation, about 7%, and you can get a hematoma or faintness. It's really rare for those, for things like faintness and hematoma and redness or irritation. And so ultimately it's very safe. There is no mortality rate with this. And if you're not overtly immunocompromised or on, blood thinners, then I don't think there's really, and those are even still relative contraindications. And I think it's still a good opportunity for doing it. And a lot of insurances are now paying for it. Not all, but some are paying for it if you've already tried other therapeutic modalities and you get to this. A little more on those outcomes, which I think is important. So Vickers did this, and this was in the Journal of Pain in 2018. It is superior to sham and no acupuncture with a significant p-value. So it has a low likelihood of not, it has a low likelihood of being, there is a low likelihood that the sham and the superior and the no acupuncture are better than acupuncture. And so it's effective for chronic musculoskeletal headaches, osteoarthritis. Treatment effects persist for a long time. So it can last for weeks and some people even months. And especially if you couple this with things like physical therapy and other treatments, it can be really, really helpful. Massage, everybody likes a massage. Haven't been able to get one of those in a while. So this is interesting. 57 patients presenting to pain clinic, prospective clinical trial. They did a usual prescription that they had plus massage, control ratings before and after, no intervention time period, and 25. So pain, distress, tension, discomfort, and degree of upset mood significantly lower. This has been repeated a number of times, and I think you just have to be careful with this. Kayla had a lot of early life trauma. If I dug into her time, she actually did have sexual assault. And so massage therapy could be really triggering for patients with trauma. So it's something to go lightly. But for a lot of people who are debilitated and not moving and not up and moving around, massage therapy, while in the initial phases can be painful, at least gets the myofascial components moving and increasing some blood flow locally and getting some range of motion taken care of and can be helpful. And again, massage is, it's really difficult to identify harm for it. It's even harder to identify payment for it. But those are just some of the data that we found for that one. And when we look for some other ones in 2010 and 2016, for this massage therapy in the acute care setting, so utilizing this in a hospital, 53% participants, 30-minute massage sessions, and then pain level reduced from 5.18 to 2.3. So it basically cut pain in half in those that were getting it. And so I'm not sure if we don't have good data. We don't have functional MRI data on this like we do for acupuncture or some of the other like biofeedback and mindfulness-based cognitive therapy. But again, if we can get it paid for and used, it can be pretty helpful. And the impact on therapy on function in pain populations, which is important because this is what we're trying to look for. So this was a meta-analysis of 16 studies, and the evidence showed the improvement in pain, anxiety, stress, mood, sleep, and physiological movement in the extremity surgeries. So it's kind of hard to argue with that. I mean, these are pretty good. These are much better studies than we have for a lot of the other stuff that we spend millions of dollars on. So what about yoga? I do yoga every now and then. I always look a little clumsy when I do it. But yoga, physical therapy, or education for chronic low back pain, they did a randomized non-inferiority trial just to find out. and a single-blind randomized non-inferiority trial with 320 participants, manualized yoga program was non-inferior to physical therapy, which means it was equivalent to physical therapy, at least in the cohort that they looked at. And treatment for chronic non-specific low back pain, an eval for chronic low back pain. There is low to moderate certainty evidence that yoga compares to non-exercise controls, results in small to moderate improvements in back-related function at 3 and 6 months. So this is function. We don't have a lot of things that improve function. Opioids sure don't. Ibuprofen doesn't necessarily improve function. So this can be helpful. It also is good for strengthening and flexibility, decreased chances of falls, increases balance. Yoga may also be slightly more effective for pain at 3 and 6 months. However, the effect size did not meet the minimum p-value in order to say for sure. So again, it's something they can do themselves. So basically, if we send them home with a videotape or put an app on their phone that doesn't need internet, then kind of everybody can do it if we give them some basic things. So if it's not harmful but has a probable positive outcome, these are things that we should be teaching and training about on a pretty regular basis. Aromatherapy, we don't have any good data for that. I always get asked about it. I like it when my laundry smells like lavender, but I can't really say that it does much. Some people can have significant allergies to some of these oils, and if ingested at higher amounts, you can actually see some not positive things happen. So it's if it helps, it helps. It's one of those that if it can fully affect placebo outcome, great. That's awesome, as long as it's not doing harm. And what about things like interventional pain? So we talked about all these complementary things, and I would still see interventional pain as complementary to this. It kind of straddles both, but spinal steroid injections are really helpful if you have a nerve root compression and radicular pain, and if it's lateral foraminal, meaning instead of the one that goes straight in, the one that goes straight in, or I'll go to the camera, if it goes straight in, then it's basically placebo. If, however, you come in from the side and you angle it properly, then it actually has a therapeutic effect that we can identify. So people who would pop in, I remember back in the early 90s, I was an ER tech, and we had a pain doc who would come in and have us set up like 5 or 6 patients in the morning when there weren't that many people, and they would do L-spine injections. So they would come in, they would pull up the steroid, they would put it in, give the steroid, and they would go out. No imaging, no anything like that. That was placebo. And they probably would have benefited from Medrol as much as they did from that if they got anything from it. And spinal stimulators, refractory neuropathic pain of identified, of defined level. Those are awesome for people who have really refractory, horrible pain that we can't treat otherwise. And they work well. Basically, it doesn't take the pain away. It just changes what it feels like. It turns it from pain into tingling, which some people can tolerate and some people can't. And the new ones, the new generators have gotten really sophisticated, and battery lives are good. So they can crank it on and off when they want, and it gives them a lot of control over their own pain relief. So that was a lot. So a whole lot of information. But I hope that you can now start to think a little bit out of what our normal box of this is what we do is, and recognize that if you have a patient like Kayla with early life trauma, some issues that she's had to deal with, and she's pregnant, or she's had a kid stay, wherever she is on her lifespan, there is a modality that can treat her that is not opioid based. And if she's on MAT, whether it be methadone, buprenorphine, naltrexone, or medications for alcohol use disorder or whatever, we can still treat pain in 100 different ways that don't include an opioid. The key is to be able to point to specifics, because I don't know, for every person here, I'm sure that when you've talked to a patient, well, we'll get you into PT, and they answer right away, PT doesn't work for me. It just made it worse. But when you dig into the second question of, well, how long did you do physical therapy? Well, I went a couple times and it was terrible. I was like, well, if I went a couple times and tried to lift weights, I'm pretty sure I would be really sore, and it wouldn't have made me any stronger. So it takes time and effort. The average time span for physical therapy to have moved somebody from painful to decreased pain and increased range of motion is 3 to 6 months. And again, we get back to that initial thing I talked about, the Americanization of medicine, in a sense of we want a pill for a problem. But people need to be responsible for their own pain recovery, just like we preach in addiction, people have to be responsible for their own addiction recovery. We cannot do it for them. They have to do it. And so the more that we can take on that same role and use motivational interviewing and, motivational enhancement therapy and stick with them and push them through and add in all of these other complementary pathways, the more likely we are to get somebody who's doing well on MAT, who has pain and doesn't relapse because we've done a poor job of treating their pain. The patient has to be a part of the decision. They have to sit there with you. You have to work through it. Sometimes it is a slog. It can be really tough to have these conversations, but it's important that you do it. And again, trying to get this stuff paid for kind of sucks, especially depending on where you live. I mean, you're in Texas, you haven't expanded Medicaid. I'm from Texas. It makes me angry. I had a family member who needed it. So I'm hoping at some point people will see leaving that much money in healthcare on the table just doesn't make sense. But right now, you can see what you can get paid for and do your best. But a lot of the things like mindfulness-based cognitive therapy or things like hypnosis, once you teach them that, or yoga, these are all things they can do themselves. So the more you can teach them to do themselves, the more you can teach them to fish, the more likely they are to catch some. And the more likely they are to not go hungry and still have some pain. So it's important that we lean into that as best we can. And the biggest piece that I find is one of the biggest failures that happens is when we set unrealistic goals and we fail to meet them, because then they're frustrated, they're angry, and they should be. Because we need to say, look, we're going to take it a little bit at a time. Our goal is to get you a little more functional and get your pain tolerable, not gone. And work with that and get your patients across the finish line, and you'll have a much better chance of getting somebody who's on MAT across something like a surgery, through something like chronic pain, and be able to teach them some behaviors where they can help themselves through without requiring outside help for everything, which is always a positive for those individuals. So with that, I'm happy to answer questions. I think we have about 8 or 10 minutes or so. So if you have questions, feel free to type those in, and then I will be happy to answer those. Also, feel free to call BS if you think that I said something stupid or push back on anything. That's perfectly fine. I think I did answer the one that said, how do you deal with high tolerance of pain and medications? I think I talked about that one. And then best approach in managing patients in MAT who had experienced severe trauma. I mean, I could give you an entire other lecture on the neurobiology and realities of trauma and how that changes all of those same pieces of the brain that we talked about. It makes them more susceptible to chronification of pain as well as risk of addiction, and is most of the population that we deal with on a pretty regular basis. I'll give it another minute or so, see if anybody wants to add a question. You go to the bottom of your screen, there'll be a little chat thing you can click. Or if you want to raise your hand, I think if you raise your hand, we can see it. Yeah, no problem, you're welcome. Uncomfortable silence, uncomfortable silence. All right. So with that, everybody, please stay safe. After working in the emergency department and having to deal with a lot of patients with COVID, it sucks. They're sick and they're young. So be very careful and do what you can. And social distance as best you can. Wear a mask when you can. And if you feel like you need to, please go protest, but be safe. And we'll leave it at that.
Thank you, Dr. Waller. I was wondering if you'd be able to share your PowerPoints, even if like a PDF version, so I could share with everybody that's in, and if not, we understand.
Yeah, no, I'll send you, I think we can send you a PowerPoint.
Yeah.
I'll see what we had set up for this, but yeah.
Okay, perfect. Well, we appreciate your time and thank you so much for presenting to us today. And if I get any follow-up questions, I can always send those to you via email and then I can post them in the course.
Awesome.
All
Great.
right.
Thanks so
Thank
much.
you, everybody.
Thanks,
Bye.
everybody.